Part 2 of these general principles for interpreting immunogenicity is a video that follows part 1, but I hope it's also independent. So if you haven't seen part 1, I hope this is a standalone presentation. What I'm going to focus here is on basically the mechanisms or the technologies that we have and methodologies for testing anti-drug antibodies. Part 1 was basic principles on the biology of how the immunogenicity response is mounted against a drug, a particular drug, and part 3 is going to deal with the clinical interpretation. So part 2, let's get going. Grab your favorite drink, tea, coffee, or other, and let's go on how do we test anti-drug antibodies. Avoid using opinions. As regards any subject we propose to investigate, we must inquire not what other people have thought. I'm going to read that again. We must inquire not what other people have thought, or what we ourselves conjecture, but what we can clearly and manifestly perceive by intuition, or deduce with certainty. René Descartes, in the Rules for the Direction of the Mind, just in case your Latin is rusty. This is rule number 6, written between 1626 and 1628. What René Descartes is telling us is basically saying, let's try not to follow what people are saying just for the sake of it. Let's try to see the facts, analyze them, and deduce with certainty. Men have sought to make a world from their own conception and to draw from their own minds all the material which they employed. But if, instead of doing so, they had consulted experience and observation, they would have had the facts and not opinions to reason about. Basically, what Sir Francis Bacon, in the Great Instauration published in 1620, is saying goes pretty much along the lines of what we first reviewed with René Descartes. And it is not just by chance that I chose these two quotes from contemporary authors of the time of illustration in Europe. This is a time when people were basically waking up in terms of thinking and not just follow what you are told and what you are told to believe. Make sure that you can have the facts, that you can have the different experimentation and data so you can draw all of the conclusions with a level of certainty. This is a list of some of the most common mistakes that I encourage you to avoid when interpreting immunogenicity. Immunogenicity equals anti-drug antibody test results. I've seen this written many different ways, but basically the most typical statement is if there are no anti-drug antibodies, the drug is not immunogenic. The anti-drug antibody assay provides unequivocal positive or negative results. Anti-drug antibodies always interfere with PK. You can see it written as if the PK is not decreased, there are no anti-drug antibodies in the samples. In other words, let's not waste money and time in testing them because everything is okay with PK. If anti-drug antibodies interfere with PK, it is always in one direction. In other words, people say anti-drug antibodies can only decrease the PK. Anti-drug antibodies always interfere with function. Another way of looking at this statement that I've seen written is if there is no decrease in efficacy, then there are no anti-drug antibodies. Again, why waste time and money in testing them? If the anti-drug antibody titers are low, there are no neutralizing antibodies. And finally, baseline anti-drug antibodies are not important. Another way that I've seen this statement is exclude these subjects who have baseline anti-drug antibody positivity from the analysis because it's not truly an anti-drug antibody because they were there at baseline. So with the talk on interpretation of immunogenicity in the YouTube series, I hope that I can go through all of these different questions and explain why, in my opinion, these are mistakes and these are not trivial mistakes. These could actually have some sort of rationale behind it, but when we look at the data, when we understand the biology, we realize that we have to really avoid making these mistakes, look at the data and draw the conclusions in every single study we look at, or if you're looking at your patient on an individual basis, what is happening there. And don't get stuck with statements that could be mistaken in that particular setting. So when we are going to analyze the results of anti-drug antibody tests, I think it's before we go on the details of how these tests are done, what do we need to know? What is the data that we need to know? Either if we're planning a study or if we're planning detection of antibodies to particular patients or group of patients, or when we are given the information and we need to interpret it. So first, anti-drug antibodies are antibodies. It's the humoral immunogenic response to therapeutic drugs. And so because they are antibodies, they're going to follow the B cell response that we understand that can have a primary anti-drug antibody response, so a primary antibody response, or it could have an adaptive memory with secondary response. And I'll go over that because that is important for us to understand. Anti-drug antibodies are humoral responses that have primary and secondary, potential secondary responses. So we need to remember what the features are of those so that we can interpret the anti-drug antibody data that we see. Now, when we talk about anti-drug antibodies, we have to remember that the drug can be an endogenous protein, which is not an antibody, or it could also be a monoclonal antibody. And that antibody is going to have several different features that we need to take in account when we are detecting anti-drug antibodies that could be antibodies to antibodies. So it is complex, and that's why we always have to pause and think of what the data is for best interpretation. And when we're interpreting the data that we are given, or when we are planning on a particular study, it is important to understand how these samples were collected for the anti-drug antibodies. Try to avoid looking at trying to interpret any kind of study, or even if it's on an individual patient, when you do not have the time frame for those results. So what do you need to take into consideration either when planning or when looking at the results? First of all, understand if you are having one or two assays for the anti-drug antibodies. I will explain a bit more in a future slide. But it is important to know if you are only looking at anti-drug antibodies using one assay, or if the particular drug could have different elements and it could have potentially different anti-drug antibody assays. So it's important that you understand what are you planning or what are you looking at. Consider the humoral response timing, and that's what I'm going to be explaining in the next slides. Consider the assay platform performance. I'm just going to explain briefly one of them, so that you understand why we need to know how was this antibody detected. There's a lot of older literature. Technology has changed, and when we are looking at any particular uh, anti-drug antibody, we do need to at least understand the different platforms, different types of assays could be providing different kind of results, even if you use exactly the same serum sample. So it's just a matter for understanding what you're doing in terms of the analysis. Also understand what is the drug half-life. So you have anti-drug antibodies, but you need to know what your drug half-life is. And when are you looking at that result of the anti-drug antibody in relation not to the next dosing, but to the previous dosing that the patient received, so that you can have an idea of what is the time after the drug administration when you are being able to detect these anti-drug antibodies and this humoral response. And then it is always good, if you're planning for this, to consider that the timing of the sampling for your anti-drug antibodies be at the times when you are also collecting samples for pharmacokinetics, because you can then do a lot more of analysis of the impact of the presence of the anti-drug antibody and the presence of the drug and how these two may or may not be interacting. If you feel that you cannot really understand or go in depth on any of these points, find somebody who can help you go through these points, but avoid making any kind of assumptions or conclusions if you have not considered at least these points. So in terms of the clinical samples, you need to make sure that you understand you have a clinical assay coordinator, a clinical pharmacologist that's helping you understand when are these going to be collected or when they were collected. But if you're planning for it or if you're looking at results, you need to remember what is the primary and the secondary antibody responses. So when we have a first exposure to an antigen, you can see there in the blue line the typical response of a primary response. You are going to have a peak, about between anywhere between the first and third weeks, you have the peak response of that primary response in terms of the B cell production of antibodies. So this is antibody concentration. And what you see basically in there, it says, maximum could be maybe around day 15 or day 20. That's normally what would happen. When you have a second exposure to an antigen, so in this case, a second drug administration, if you mount a secondary response, which means now that your adaptive system has developed memory and these cells are primed and will respond, the time frame for being able to detect the response is also, after the second exposure, it may take a month or 15 days to a month to actually be able to detect it. But what's important here is the titer booster. Now, on purpose, this particular graph does not have a number, but it is very clear here that the magnitude of increase in terms of the titer of antibody in a secondary response is at least 3, if not more, times higher than the highest response seen in the primary response. So in other words, if your titer is 1 at the maximum level of the primary response, in a secondary response it goes way higher than 2, probably even higher than 3 at the maximum time. but by the same amount of time after the drug administration. If the primary response continues and you never mount an immune response, you should be able to just look at the titers. And if the titers are very similar from the same drug administration to the second, and let's say within 15 days to 3 weeks after the drug administration in both cases, if the titers are very much similar, then you probably are not dealing with a memory response to your drug. And that's usually good news. Primary response would not be maturing, and it can be sort of a background response and not really affecting, at least in terms of safety, in a significant way. Having a secondary response, it is actually probably going to be perpetuated. It's a secondary response, means there's memory to that response. And when your patient receives the next dose of the drug, most likely those antibodies are going to be present. Now, the antibodies to the drug may have an impact on efficacy. They may have an impact on safety. They may have an impact on the drug metabolism, or they may have absolutely no impact at all. So it is important to know that when you're analyzing this data, don't forget there's patients behind the data, and you always have to look at clinical manifestations. This is going to be part 3 of clinical interpretation. But again, remember, this is the primary and secondary response in terms of the B cell antibodies titers, and this is why it's important to look at levels of the titers and titer booster. It is also very important to understand what is the isotype and what is not only the titer but the isotype. So when we actually look at this graph, which is similar to the one I showed you before, what you see there is the isotype switch. So as I mentioned, if you maintain a primary response, which is shown here in the red, it's typically going to be an IgM response. The titers will be, probably maximal anywhere. It does depend on the type of antigen and the experimentation, but usually between the day 7 and day 21, as shown in the previous graph, you will actually have the maximum titers. So you will see the primary response occurring and then slowly going down. And when you have a second drug administration, if the response maintained primary, you will just eventually see always the same. This could be detected depending when you have your anti-drug antibodies selected for the different sampling collection. You could actually see them as, positive, negative, what people sometimes have called transient titers. But basically, important things, look at the titer. If your titer is presenting with at least a 3-fold, 3, 4, or even higher fold titer booster, this is critical because this is really what's telling us there's a secondary response, and it's actually a switch in the isotype. So most of the times the isotype assay is not necessary as long as you do have the titers of the antibodies. You can explain, you can actually interpret what you're seeing and be able to see if an individual is having an antibody to the drug. You make sure that you have the timing of the sampling collection in relation to when the dosing occurred, and that timing is within the time that you would be expecting to see at least readable titers, and especially after a second exposure or future exposure to the drug, you will now see if these titers are getting a booster in the titer or if they're maintained, which basically will tell you is more likely to be a primary response. Now, some of the drugs are administered more frequent than what this particular dose is showing. And when that happens, then what you can see is a titer booster much faster than in the case of doses that could be a month apart. So then the other thing you need to consider is anti-drug antibody response to antigens. And so when would you have this condition when you're talking about anti-drug antibodies? Well, does the design of your particular dose schedule include drug transitions? Are you treating a patient with a particular drug, a particular manufacturer, and you're going to change? It's the same drug, but is it now transitioning to a different manufacturer? Or is your drug having a pegylated portion? In either of the two cases, you might actually want to consider if there is a potential response to two different antigens. So in the first case that I want to discuss is when you have your first antibodies. This is again in blue, the primary response, and again we're seeing anywhere between 7 and 21 days you will have the maximum titers of a primary response. This is in blue. So let's say this is what's happening when your patient is first receiving or continually receiving a particular drug. And then you find the opportunity of that particular patient to switch to a different manufacturer. And you would be detecting what it's in here. If it's antibodies to B in red, this would be like another primary response. And if the patient maintains that primary response, that's fine. However, what you could also be detecting is if at the time of the change there's a titer booster. And you can see here it is the titer booster is not something you're going to miss. It's at least threefold, if not more, in terms of the titers. So titers are very, very important. And this is good to know if that particular switch has produced now a secondary immune response to the antigen. And the same thing could be said for pegylated drugs. You could consider if patients actually have anti-peg antibodies, and this would be on the left portion of this graph. You have anti-peg antibodies, which are, by the way, relatively frequent in different populations. You may have anti-peg antibodies in circulation. But now you are giving, when it says second exposure, what you could be giving now for the first time is a drug that has a pegylation. And so you need to follow the titers of these anti-drug antibodies now. Are patients who had baseline or previous antibodies to PEG maintaining a primary response to both the pegylated portion and the drug that's pegylated, which would be antibodies to B. So are you maintaining a primary response? That should be okay, but it could be a situation where the anti-PEG antibodies at baseline could be predisposing to a memory response, secondary immune response, with a dramatic increase in the titers. So that's important to know. What is it that you are looking at? What is the assay that you are looking at in terms of the results, and how do you interpret in terms of what was the patient receiving in all these instances before and after you receive these tables or graphs with the titers of the anti-drug antibodies, so that you can make interpretations that are correctly interpreted based on the facts. So looking at the clinical plans for anti-drug antibody testing, remember the primary and the secondary humoral response. It does depend, but generally 10 to 20 days after the first exposure is when you are going to have a primary response, also secondary, but it's when you're going to have the titers increased in a way that you can actually measure them. And if there's a memory adaptive response in the secondary response, there is going to be a titer booster. This is going to happen after a second exposure. Now, sometimes there's a baseline before a patient has ever been dosed. They may have some antibodies that could have been not necessarily very selective or specific for the drug, but they may have baseline antibodies that can predispose to a secondary memory response to the drug. So having these baseline antibodies is a key for interpretation. You need to know if they had them and if these particular baseline antibodies predispose patients to having memory secondary responses with titer booster. So titers are very important. Isotypes, I would say it's another level of complexity in terms of validation of these assays, etc. It's not that simple. But titers is something that should be always reported with the results of antidrug antibodies, and titer boosters are critical for the interpretation of that humoral immunogenicity response to drugs. Remember, consider the time in relation to the last dose. Oftentimes, we are actually seeing protocols written that are very clear in respect to the next dose. It says collect before a dosing. But what you do need to know when you have the results is in relation to the last dose, because that's going to help you interpret the titers and the responses. As I mentioned before, consider if you can plan for this, having your samples collected for antidrug antibodies at times when you also have samples for pharmacokinetics, so you can actually see if there is any effect of antidrug antibodies in the blood and the pharmacokinetics of those particular drugs. So you can assess if they're increasing or decreasing the drug concentration or half-life. The drug half-life is critical for understanding your responses to the drugs, because it will remain in the blood for a certain amount of time, and that can actually impact the anti-drug antibody assay and the results. That is referring to drug tolerance and also target interference that I will be talking about. So before we go into the assay for detecting antidrug antibodies, I just want to remind you a more thorough explanation was done on part 1 of the immunogenicity series in YouTube. But just remember that you have a drug. The drug can be an antibody or a protein. This particular drug has a drug target. The drug target can be soluble, as shown on the left, or bound to a membrane, as shown on the right. So you have a drug and you have a natural drug target that is in the human beings that you want to modulate. When you have anti-drug antibodies, they could be binding the functional site of the drug, and so this is what we know as neutralizing antibodies, and they may be competing with the natural target. So in other words, these anti-drug antibodies can decrease the efficacy of your drug. The anti-drug antibodies could also bind outside the antigen binding site, and your drug could still be able to engage with the target. In these cases, because it's binding the Fc portion, and the Fc portion has several effector functions, you need to understand if this particular binding outside the antigen binding site is impacting efficacy. For more details on what I'm saying now about how they can affect efficacy even if they're binding outside the antigen binding site, or in other words, if they're not neutralizing antibodies, they could still be impacting efficacy. Please see part 1 of immunogenicity series. So the first thing I want to mention is there are many different ways of measuring antidrug antibodies, different methodologies, different platforms, and of course, technology always advances and changes. So I'm talking 2018, and in 2018, the MSD platform for anti-drug antibody assay is the one that has been developed and better characterized, and it provides a better platform or technology for measuring anti-drug antibodies compared to older methodologies. And I'm sure that in the future we may have even better ways of measuring. But I will explain briefly what the MSD platform is. So what happens is basically we have our drug, and depicted here in the salmon color is if our drug is an antibody, and in the green color is if our drug is not an antibody but a protein. In either case, they could be antigenic because they're proteins. I have explained a bit more about this in part 1 of the immunogenicity interpretation series in YouTube. But anyway, we have proteins. They can be antibodies or not, and we're going to detect antibodies to the protein. So we actually use the same drug that we are giving to the patient as the solid phase capture, and it's now bound to the platform where we are going to be testing. So we use the drug on the platform, and we use it to then wash over serum from patients. So if the serum from the patient has anti-drug antibodies, and remember we have used the drug the patients received on this capture platform, if the patient sample has anti-drug antibodies, they will bind to this solid phase drug because they are anti-drug antibodies. And then we come with the same drug that's labeled. Because these are anti-drug antibodies, they will actually bind to the labeled drug that we're washing over. So the anti-drug antibody was stuck to the plate because it's binding the solid capture drug, and then because it's bound to the drug on the solid phase, when we use the labeled drug, it will be able to identify the anti-drug antibody. So basically, we use the drug to detect anti-drug antibodies, and it's a very straightforward assay. What are the challenges? Well, there's situations where we could have false positive results or false negative results. Let me walk you through the explanation in one case of the false positive results. So if your drug binds a soluble target, the patient's blood may not have anti-drug antibodies, but they may have the soluble target in circulation. And remember that we are using the drug as a solid capture and the drug as the labeling agent. And this drug has been engineered to bind the soluble target in the patient. So by the nature of this particular platform, if the target of your drug is soluble, it may be circulating, and the patient may not actually have any anti-drug antibodies, but because you have the target that's soluble, it binds the drug on both ends, and it will be producing a false positive result. This is what's called the target interference. And there are several different protocols for validation of the assay where, depending on what the target is, the serum samples from the patient can be incubated, prepared to make sure to get rid of that target in the blood without getting rid of the potential anti-drug antibodies. And then that sample can be tested once you wash it from having target in it. So these are different types of protocols that are used. They depend on the target, and that's why it's very important that you know that the results you're getting from any given protocol or patient, that you understand these have been validated. In the validation for this particular interference of the target, you also need to understand what is the characteristic of that particular assay. Is the pre-treatment successful 100%? Or is it not? And what is the probability that you could have a false positive result in this particular situation? So not one size fits all. When you get results, not just look at the results and think that because you've been in another particular situation or with a different drug, you've been able to analyze samples. Drug to drug is different. So don't assume that the same validation is making all of these different assays the same. So just make sure that you take a look or you contact individuals in this area that can help you understand if there's target interference and how to interpret these results. So that's for the false positive. Now, the other situation is if the patient has anti-drug antibodies, but they also have drug in circulation, especially when you have the maximum concentration of the drug in circulation. It is very likely that if the anti-drug antibody can bind the solid phase, well, the other potential binding for the labeled drug is occupied by the drug that's in circulation in the patient. So in this case, the drug itself is producing a false negative result because this patient has anti-drug antibodies, but they also have a lot of drug in the blood. This is called drug tolerance effect. And it's one of the reasons why in old assays and old methodology platforms, and probably some new ones where you cannot detach these two successfully, recommendation was wait until the half-life of your drug is passed before you do any anti-drug antibodies, because you may be getting exactly when you are expecting the peak titer response from a primary response or a secondary response anywhere between 7 and 21 days after the drug is administered. Well, that could be when your drug is also in the blood and you could be getting false negative results because of this particular situation. Your anti-drug antibody is higher titers, but also it's higher concentration of the drug, and you're not able to detect it using this particular platform. So again, there are some protocols that depend on the very specific drug. They should be validated. And when you're looking at the results, you need to understand what was the validation in terms of the drug tolerance. So sometimes the samples from the patients have to undergo some pre-incubation. Sometimes is, conditions of pH or temperature. It depends on the drug, and it depends on the particular validation of the assay that you're looking at. how are they getting rid in the laboratory of the drug that is now bound but maintain the anti-drug antibodies in the blood for the assay. So in both cases, you need to understand if the assay has the potential for target interference, and would you be seeing some false positive results, and likewise, can you see potential for false negative results, and what was the validation of your assay in terms of the drug tolerance, and was that followed when you received the results for the anti-drug antibodies for either a particular patient or a study. So in terms of the plans for antibody testing, anti-drug antibody testing, remember you have to consider if you're looking at one or two assays, and then you need to understand if they should cross-react or not. How are the two anti-drug antibody assays telling you? What are they telling you in terms of the patient's response? So what is the kind of information you need before you start interpreting? Are you giving two drugs, or are you having a pegylated drug? Are you looking at a potential patient who has been on one manufacturer and then you change manufacturers? How do you interpret these anti-drug antibodies? And are you using one or two assays? Consider what is the time of the sample collection. So it is important to understand the primary and secondary humoral response. So you should be able to have some, between 10, 20 days, 7 to 21 days, let's say, of the exposure or the drug administration, I should say, and look at titer boosters. It's very important that you understand looking at the titers, not just at the anti-drug antibody response. And if you ever get a table that you need to interpret and it just has overall percent of patients that have anti-drug antibodies, that's really not very useful. You need to try to find out the time frame in relation to the drug administration and the titers. So if isotypes are available, that's fine, but I really think that validation of isotypes is more complex. It probably is much easier just to assess the titers, because believe me, a titer booster, you will not miss it. It's going to have to be at least threefold, if not higher, and it's very typical of a secondary response. And again, think about the relation in terms to the last dose, not in terms to the next dose, which often is done, but dig around and find out from the last dose, when am I getting these results? Are you getting very low titers because the first time they were tested was 6 months later? Well, you may not be able to articulate if there was a humoral response that could have been a primary response, and then you're no longer able to detect it because it's too late. Or is it too soon? So you need to just understand the time. And again, consider when you have the samples at the same time of the PK samples. I will be discussing a bit more about this on part 3 of the immune response and immunogenicity interpretation in part 3. So the potential effects that the anti-drug antibodies can have on PK are very important. And finally, consider the drug half-life and how the validation of the assay was done, and understand a bit about the drug tolerance and target interference when you are given results, or find out an expert who has ability to understand this to help you in the interpretation of the data. So going back to several different concepts when we are testing anti-drug antibodies, the MDS platform, because it's using the whole drug and serum from patients, if they have antibodies, they bind that drug that's captured on the solid phase, and they will be identified by the labeled drug. But it could be, this antibody could be binding anywhere in the drug. Now, to identify if these anti-drug antibodies are neutralizing, there are many different ways to do it, but again, looking at the capture on solid phase, if we have the particular drug, we know that the drug has been engineered to bind a particular target in humans. So this particular target now is labeled in a way that when it is engaging the drug which is captured on the solid phase, we put the incubation with a target, and this target is labeled so that it produces a response the moment it actually is bound by the drug. This can be read as a signal, and this would be a way that we normally see the drug is actually working, having its mechanism of action measured. If a particular blood sample carries anti-drug antibodies that are neutralizing, what will happen is that the blood from the patient has the antibodies that now bind to the drug in the active site, and there's no signal. So even when we incubate with a soluble target, the results will actually be negative in terms of no signal, and it will be an indication that this anti-drug antibody is a neutralizing antibody. So it neutralizes the function of the drug in vitro. Neutralizing antibodies can also be done using cell-based assays. And this is the case when the target of the drug is cell-bound. So when our drug is targeting a cell-bound target, we need to use those cells. Well, we can use the cells that carry that receptor. We incubate it with the drug that's captured in the solid assay, and then that particular interaction targets these cells which have been labeled in order to produce a signal. When we incubate now this drug with the cells for the assay, but we previously incubate with blood from patients and they happen to have a neutralizing antibody, it means that the functional antibody binding site will not be able to engage with the cell receptor. So basically what happens is the targeted cells will not produce a signal. And this is what will, in a cell-based assay, detect a neutralizing antibody. There are many different assay designs or processes. There's many other different ways to read out, but this was a simpler way of explaining the difference between the neutralizing antibody assays when you have a solid soluble target, or when we have a cell-based target. Cell-based assays usually may take a little longer in providing the results. So it is important for you to understand, if you are getting a result of a neutralizing antibody, what was used in both cases, and understand the results. To create this particular file and the animations and the cartoons, I have consulted many different literature reviews and different papers, but these are the ones that I would highly recommend, and I will put them in the YouTube description. Thank you for listening.